and they contacted me saying, listen, Dr. Washton, I've never used heroin in my life. I've never stuck a needle in my arm for anything, and I don't think I ever will. The drug I'm using is not heroin, but it's cocaine. Everybody tells me cocaine is not addictive, but I keep trying to walk away from it, and it keeps calling me back. So all of a sudden, I was confronted with one person after the next contacting me about getting treatment for a cocaine problem, supposed cocaine addiction, although nobody was willing to call cocaine addictive back then. I got the idea from these people that there were many others like them suffering with this problem, but no treatment was available. There was no such thing as a cocaine treatment program. Nobody was willing to call cocaine addictive, as I said. I got the idea to set up a cocaine hotline.
This is Shiva from Therapy Everywhere, and welcome to our first episode of a new series we're starting with Dr. Washton. If you've been lucky enough to listen to some of the Conversations with Therapists episodes that we've been doing with Dr. Washton, you'll know that he's an expert in addiction therapy and is such an exciting and insightful person to talk to about this topic. So much so that we're starting a new series on the channel, which is centered around Dr. Washton and his work. In this episode, we talk a little bit about Dr. Washton's background, as well as how he was a pioneer for cocaine addiction treatment in the US, specifically how he started his cocaine hotline. If you need help with addiction or substance abuse, please make sure to look at the resources below. I hope you enjoy the episode. Welcome, Dr. Washton.
Yes, hi, Shipra. Daniel, good to see you again.
It's great to be here. I'm really excited for this conversation. To start, I was wondering if you could tell us a little bit more about your early life, growing up in the Bronx, and how it influenced your career path. We've been talking to you on a couple episodes now of Conversations with Therapists, and I want to get more deeper into who you are.
Well, as you just mentioned, I grew up in the Bronx, New York, and during that time, certainly drugs were around. It was more during the heroin epidemic of the 1960s. And, I was fortunate that personally I was not affected by that, but I did see people in the neighborhood. I knew two kids when I was a teenager who died of heroin overdoses, so I saw it firsthand. These are people I had relationships with. I knew nothing about the problem, about the illness at the time. All I knew is that they had tragically died at a very young age and saw the suffering that their families went through. Um, when I was in school and did my training, there was no such thing as addiction psychiatry, addiction medicine, or addiction psychology. Addiction was not seen as a legitimate field of study or practice. In fact, if I was taught anything during my graduate training, was that addiction was too difficult to treat, that we'd probably be better off leaving that problem to others, and that we would focus on the more common types of mental and emotional problems, depression, anxiety, and the like. So I, like many people of my era, got no formal training in the addiction field. I've only been a teacher in the addiction field, never a student. And I got into the field really by accident. I took a part-time job, moonlighting job in an addiction research center in Manhattan that happened to be located at New York Medical College that had a heroin addiction treatment clinic in the East Harlem section of New York. And it was an interesting place to work because it was not just treatment. Every patient was also in a study. The clinic was supported by grants from the National Institute on Drug Abuse. So for the first 8 years of my career, I worked in an addiction research and treatment facility. We were helping to develop new treatments for addiction. That's the clinic in which naltrexone was first given to recently detoxified people who are dependent on opioids to help prevent relapse. We did trials with long-acting forms of methadone and other medications. And most importantly, it was a clinic in which we looked at the effectiveness of behavioral interventions, various forms of psychotherapy in combination with medication versus medication alone or therapy alone, because we were of the conviction that the combined treatment was likely to work best, but we wanted some scientific data to support that. Fortunately, the study did turn out to demonstrate that. So that was a very important finding. So I worked in that clinic I started there in September 1975 as a staff psychologist. By the time I left that clinic in 1983, I'd become the director of the facility. My mentor, who hired me originally, retired along the way. I took over as the director of the clinic. It's a large clinic that treated maybe 400 patients at any given time. We had a staff of about 25 people. So I began just as a staff psychologist, and I ended up being the director of the whole facility. And that was a learning experience that no formal education could duplicate. Spending that time from 1975 to 83, spending those 8 years working on the front lines of addiction research and treatment taught me a great deal. And most of what I learned from talking to the patients.
What inspired you to continue with it after those years, to continue with addiction psychology?
Well, a very interesting and unexpected thing happened around 1983 in this clinic, which was located in East Harlem. It was mostly a minority neighborhood. And that was, those were our patients in this clinic. But I started to get requests from executives and professionals who learned about me because I had published a variety of studies on the effectiveness of different kinds of treatment. So I had established myself as, an academic, a person, a researcher, and a clinician. And they thought maybe somebody like that would have some cutting edge information. And they contacted me saying, listen, Dr. Washton, I've never used heroin in my life. I've never stuck a needle in my arm for anything. And I don't think I ever will. The drug I'm using is not heroin, but it's cocaine. Everybody tells me cocaine is not addictive, but I keep trying to walk away from it, and it keeps calling me back. I'm spending enormous sums of money on it. It's starting to disrupt my functioning. This person that I'm talking about could be a lawyer, could be a Wall Street executive, could be the owner of a business, could be a housewife, could be a physician. So all of a sudden, I was confronted with one person after the next contacting me about getting treatment for a cocaine problem, supposed cocaine addiction, although nobody was willing to call cocaine addictive back then. In fact, in the DSM, there was no category of cocaine dependence, only cocaine abuse, because cocaine, like other stimulants, and unlike opioids like heroin, does not produce a classic withdrawal syndrome when you stop using. What happens is that you get cravings and urges, but you don't go through a physiological withdrawal. There's no medicine you give a person coming off cocaine that will stop the withdrawal like you would if they were addicted to opioids. I got the idea from these people that there were many others like them suffering with this problem, but no treatment was available. There was no such thing as a cocaine treatment program. Nobody was willing to call cocaine addictive, as I said. And each of them said to me, I have lots of friends. I know so many people who are in the same predicament as I am. We keep going around looking for treatment, and the only answer we get is cocaine is not addictive. If you want to stop, just stop. Sort of like, an addiction to some kind of food or cigarettes or something else. I got the idea to set up a cocaine hotline, which was just the telephone on my desk in this clinic in Harlem, and went to the local New York Rock FM radio stations and said, would you play a public service announcement, but please just play it in the middle of the night, sometime after 1 a.m. I wanted to catch the cocaine users crashing from cocaine, feeling desperate for help. And it was a very simple message. I recorded in my voice, and it said, if you or someone you know, someone you love has a problem with cocaine and wants professional help, call Dr. Washton on the cocaine hub. This was in 1983. There were no articles in the newspapers, no articles in the journals about cocaine being addictive at that time. I never anticipated the response. It was astounding. So I put a answering machine next to that phone on my desk, And back in those days, they were pretty primitive answering machines, perhaps before your time, but it had two cassette tapes. The outgoing message that was on one cassette, and the incoming messages were recorded on another cassette. And you could call in remotely to get your messages. I had this little beeper device. You beep it into the phone. It sent a signal to the machine that would rewind and then play the messages back. And you knew roughly how many messages you had by how long it took the tape to rewind. Okay. And it had about a 100 message capacity for brief messages, 15, 20 seconds or so. The day that the hotline became active on the public service announcements on the radio, they wouldn't tell me in advance when it would be. It would be whenever a slot was available. I happened to be on vacation with my family in Florida visiting my mother. And I called the answering machine and beeped into the phone. And I sat there, my jaw dropped, because the tape kept rewinding and rewinding and rewinding all the way back to the end. There would have been more messages on the tape if it had greater capacity. And I'm sitting there in my mother's apartment in Miami Beach, listening to one person after the next saying, I have a problem with cocaine. I can't find help. If there's something you can do for me, please call me back as soon as possible. I got roughly about 100 messages like that. I took the first plane I could get the next morning. I went back to my office in New York and started calling these people back. I asked them to come in for an interview, get more information. There was clear evidence that they were addicted to cocaine in the behavioral sense, not necessarily the classic physiological sense, in that they had a compulsive attachment to the drug. Every time they tried to stop using it, they got caught up in it over and over again. It was causing problems with their families. It was impairing their functioning at work, whatever their job happened to be. They were spending enormous sums of money on cocaine, and they couldn't find anyone to help them. So I constructed a 30-item questionnaire to interview people over the phone who were calling the hotline to get a profile of who they were and the nature of their relationship with cocaine. I analyzed, collated the data. I wrote up a brief report known as a letter to the editor of the Journal of the American Medical Association and the Lancet, which is a British medical journal. Both of those journals have sections called letters to the editor, in which you can publish, breaking news, breaking findings of interest to the medical community. And the Lancet published my article entitled Intranasal Cocaine Addiction. That is, the point was, even by snorting cocaine, you could get addicted to the drug. People thought previously, well, if you injected it like heroin, maybe you'd get addicted. But certainly snorting cocaine was a, harmless pastime. It was known as the drug of the rich and famous way back then. It was even referred to as nose candy. All kinds of, harmless connotations, and the drug obviously is far from harmless. When those articles hit those journals at the time were monitored by the wire services. There was no internet at that time, and Knight Rider and other news services picked up on it. The news spread like wildfire. Before I knew it, I was, on television just about every day on Good Morning America and Nightline and CBS Evening News and McNeil, Lehrer, PBS News Hour, went on Oprah Winfrey. At the time, there was a talk show called Phil Donahue. The study was quoted in major newspapers, including the New York Times. And kind of overnight, I became the nation's cocaine expert. I didn't have all that much experience with it, and I was asked to come to Washington to meet with the president's advisors. At the time, was President Reagan. I was asked to testify before special committees of the U.S. House of Representatives and Senate about the cocaine emerging cocaine problem in America. I mean, my world changed almost overnight from having done that work and published that study. And I ended up starting what probably was the first formal cocaine addiction treatment program in the country. And so I went from treating mainly underprivileged people in the in inner city neighborhood in Manhattan, in East Harlem, to now being besieged by executives and professionals, mostly white upper middle class people who were struggling with cocaine. And I ultimately left my job at the clinic in New York, and I set up my own program. It was known as the Washton Institute. It was on Park Avenue in Manhattan, and it was a clinic that was dedicated to treating high functioning people with cocaine and other drug problems. Of course, people came in for all kinds of problems, alcohol, of course, but at least people with cocaine problems knew that they had a place to go where they could get specialized treatment that was focused on their particular problems, and also that they could connect with other people that they could identify with. Because it wasn't a public clinic, it was a private clinic, and the people coming there, felt comfortable being in that kind of environment. That kind of launched my career, as you can hear, into treating higher functioning people with cocaine and then, of course, alcohol problems. And so when the opioid epidemic hit in the early 2000s, the prescription opioid epidemic, it affected the same population. Of course, it affected everybody. I mean, it's often said that addiction is an equal opportunity disease. It knows no social, economic, ethnic boundaries, which is absolutely the case. And the prescription opioid epidemic, for the first time, really brought into that particular epidemic of those types of drugs, opioids, a more middle class functional population, because previously we only knew about opioid addiction mainly among people who were injecting it heroin intravenously. Now people were using Oxycontin, Vicodin, Percocet, other prescription opioids in a much more discreet way, getting them from, prescribed by doctors rather than buying them on the street. We saw the emergence of prescription mills here, where with indiscriminate prescribing of these medications. And it started to have public health consequences in terms of massive increases in overdose rates, for example, and particularly as it spread to adolescents and young adults, and the death rates went up. So my career has gone from treating inner city people with serious heroin addiction problems to treating the more middle class cocaine users, to then opioid users, and a broad population of people in terms of the substances they use and where in the course of their addiction they happen to be. Along the way, I took the time to write a couple of books to share with my colleagues and others the benefits of what I was seeing. My first book was Willpower is Not Enough, which was written for the general public, which is about, the commonalities and addictions of every kind, whether it's alcohol, heroin, cocaine, other drugs, or behavioral addictions, compulsive gambling, compulsive sexuality. And then went on to write textbooks for my colleagues, first on treating cocaine addiction, which was an outgrowth of the experience I just described. And more recently, my textbook, the second edition of my textbook on treating alcohol and drug problems in psychotherapy practice, Doing What Works. That second edition just came out a few months ago. The original one was published, I think, in 2012, together with my esteemed colleague, Dr. Jones Wieben at the University of California in San Francisco. And so these days I am in solo practice. I treat mainly executives and professionals. About 50% of my patients are physicians, recovering from addiction. The others are people in various types of work, retired, executives in financial industries, people who own their own businesses, people who have a lot to lose by continuing their substance use. Nonetheless, some of them do struggle, some of them do suffer tragic losses as a result of their substance use. But in the main, I'm happy to say that I continue this work now 49 years later. People ask me, like, why do I continue to do this? And I say, because I like to see people get better. Despite the common misbelief that addiction is difficult, if not impossible to treat, that everybody relapses, that trying to help these people is a waste of time and energy, I feel exactly the opposite. What's kept me in the field is seeing the miraculous changes that many people go through. And I have a great deal of regard for the patients I've seen over the years in terms of their ability to apply their effort, their determination, to overcoming this serious problem.
I guess I have sort of two questions in one for you. First of all, I'm just sort of amazed at how you managed to sort of see a problem as it was happening. I think that's very difficult to do. It's very easy to kind of look back on something and say, like, oh, we didn't know that was going to be such a problem. But it sounds like you really tapped into the idea that cocaine was addictive and that it was going to be more of a problem than it already was before, a lot of experts did. And I'm wondering, like, how that thought process sort of came to you, and if you knew kind of what you were touching on before you touched it, or if it was just kind of a feeling. And also, I guess you were just talking about your patients. I want to know what is sort of like the most rewarding things that you've seen from being in this work. How has it affected you, or what are things that you've seen that have really made you feel like this is something that you are going to continue to do?
Well, with regard to your first question, I would like to say that, that I was a futurist in the making, that I saw it coming, and was smart enough to pick up on it. I think my patients were telling me everything I needed to know. And I think one of the factors was certainly the marked contrast between the patients I was treating in the clinic in Harlem and the people using cocaine who were seeking my help. I had had no contact with that population before, and it really got my attention. That is, you mean doctors and lawyers and executives and people making substantial amounts of money with good jobs, intact families, who show no signs of serious mental illness could get addicted to this drug? Wow, that really got my attention because it flew in the face of all the stereotypes of what addiction was about at that point. Also, anything I'd heard about cocaine, I had no personal experience with it, but anything I heard about cocaine suggested that, it really wasn't a particularly addictive or dangerous drug. I heard people speaking about it in casual ways, and my experience just flew in the face of that. Well, I think what's been most rewarding for me working as an addiction specialist has been the opportunity to see people overcome tremendous adversity and get better, and to see the changes in their lives, in many cases sustained changes, the ending the suffering of their family members and themselves. Despite the stereotypes, and perhaps this is also indicative of the patient population that I treat, which is a fairly selective one, that the success rates are pretty good. These people, the people that I treat, they have a lot to lose. In some cases, they've already lost a lot and they have a lot to regain. I think for anybody in this field, what motivates us to continue the work is the fact that addiction treatment does work, and it works if it's individually tailored to the needs of the individual, to the person being treated. that if you don't try to approach it in a boilerplate way, but you try to approach it as an individualized treatment approach, and find a way to connect with people, start where they're at, not where you'd like them to be, and hang in there with them through the ups and downs, because the progress is rarely linear. People take 2 steps forward, 1 step backwards. And unfortunately, in the addiction field, at least historically, there's been a tendency to think in black and white terms. You're either abstinent or relapsed, one or the other, and there's no in between. We've kind of looked at addiction like pregnancy. You either have it or you don't, and there's nothing in the gray area.
Right. That's really interesting. It's amazing to hear the extent to which you have changed the field of addiction psychology. How would you say in other ways that addiction psychology has changed in the time that you've been working in it?
Well, the addiction field has changed over these decades, mainly in terms of the increasing appreciation for treatment having to fit the needs of the person. I think we have been gradually, slowly, I wish it was happening more quickly, moving away from the one-size-fits-all mentality, that there's just one preferred or best way to do this, moving away from the idea that anything short of total sustained abstinence is failure, recognizing that addiction problems often go hand in hand with other emotional and mental health problems. What I often say to my colleagues in my lectures is that addiction never develops in a vacuum. That is, in all the years that I've been practicing, I cannot remember a single person who came seeking my help who, when we reviewed their history of involvement with substances, said that their addiction developed during a time in their life when they were reasonably happy and self-satisfied. Happy people don't get addicted. I think that's a fundamental premise. And if that's true, it means that once the substance use behavior itself stops or is markedly reduced, there are other issues that have to be attended to, because what also I think is universally true is that people who become addicted, along the way, were using alcohol or other drugs as coping tools. And so the substances came to acquire a special meaning and a special value, and became much more powerful reinforcers than would otherwise have been the case if people were using substances to help them have a good time, or, to relax a little bit and have fun. Once people become addicted, you can see in the course of the developmental course of that addiction that the drugs or the alcohol started to take on different meanings and play a different function in their life. Not that this was conscious. It wasn't like, oh, I'm feeling upset, let me use this or that. Or I'm feeling depressed or anxious, so, I want to drink, I want to do that. That does happen. There is connection between, negative mood states and substance use, but it's never the singular cause. So the field is evolving because we have more mental health professionals involved in addiction treatment than ever before. We have more psychologists, more clinical social workers, people who are trained as professional psychotherapists and mental health clinicians in the field. And so appreciating that this is a complex problem with multiple causes and etiologies, and that the treatment has to be multidimensional, not singular or unidimensional. That's the biggest change. The other big change is that we have new and better medications now than we did before, mainly for opioid addiction. We still don't have really good medications for alcohol, no medications for cocaine problems. The greatest advances have been in medications for the treatment of opioid addiction. And so medication, what's become known as medication-assisted therapy, which is a behavioral psychosocial type of treatment where the medication is an adjunct to it to facilitate the work, is becoming more and more utilized in the field, which I think is a very positive development.
I remember the first time that I saw the rat park experiment, what you were just saying really reminded me of that. I'm sure you know of it, but for those who don't, uh, or Daniel, I'm not sure if you've heard of it, but basically they put a rat in a cage and they had two bottles. I'm pretty sure this is what it was. They had two bottles. One was like laced with heroin or something, and the other one was regular water. And they did it like the rat was completely alone, and they didn't give him anything to do, and he got addicted to the heroin. And then they had a separate cage which had the same setup with the water, but they had like the most fun, exciting thing for the rats. And yeah, those rats drank the regular water, and I found that like so interesting to hear, and it's exactly what you were saying before. And I think like sometimes the idea of like emotional connection and behaviors to addiction is sometimes hard for people to understand, because I think for those who aren't involved in it, they might just say, you know, just don't have that drink or just don't take that drug. But with all addictions, it's not as simple as that, and it's you know very it's
Well,
just
it's the old Nancy Reagan thing, just say no.
Mhm. Oh yeah, exactly.
Doesn't work.
But it doesn't
Yeah.
work. I guess also what's so interesting about the medications, I know we touched on it a little bit, but I guess more as time goes on, more and more advancements are being made in the field, in terms of things that can help people with addiction that goes beyond just therapy. Are there like new things that you're excited about, or things that you know you're excited to explore as we move forwards?
Well, of all the new medications that have become available in the past decade or so, I think the most exciting development has been the availability of buprenorphine, generally known as Suboxone, for the treatment of opioid addiction. And in some ways, it's almost the perfect drug for treating that problem, because uh, if somebody's physically dependent on an opioid and they're given buprenorphine, it will stop withdrawal. It will prevent it from coming back. It reduces and eliminates cravings. Um, it also happens to be a very good antidepressant and anti-anxiety agent. So people generally feel more normal and better on the medication, and it doesn't get you high. So there's virtually no euphoria associated with it. So somebody maintained on buprenorphine can live a normal life and uh, be relieved of the possibility of relapse or overdose. And it's an extremely, it's got a high acceptance rate among patients who take it and are willing to go through the process of getting inducted onto the medication and have the dose adjusted properly for them. The biggest problem with buprenorphine, like other treatments for opioid addiction, is when people stop taking it, the relapse rates are very high. And especially for young adults, the overdose death rates are very high. If you have an opioid addicted adolescent or young adult who's done well on buprenorphine and stops it abruptly, the possibility of dying from an opioid overdose is significant. So there is an anti-medication bias that we still struggle against. The idea that, is it a bad thing to have to take a medication every day in order to keep your addiction at bay? If all it does is, help your functioning, prevent relapse, should you feel stigmatized by the idea that you, quote, have to take this medication every day in order to get its benefits? Well, certainly in the eyes of someone like me, no, of course not. It's like asking a diabetic about insulin, or people who have other kinds of hormonal deficiencies like thyroid or whatever have to take medication every day. There are so many medical physiological problems that require maintenance medication, sometimes for life, that we don't have a bias against. But when it comes to addiction, it's got a strong social stigma that these other disorders do not, and for obvious reasons. Listen, let's face it, alcohol and drug abuse uh, produce pretty gross distortions in people's behaviors and personality. And it produces changes in behavior that can have public health consequences, that people can engage in dangerous behavior that adversely affects themselves and other people. Addiction severely disrupts families. marriages, other relationships, parenting, um, child development, that you don't see with many other disorders. I think it's the fact that substance use disorders are, by definition, uh, include severe behavioral disorders. And it's amazing how much of that stops when the drug use stops and the alcohol use stops. So I think that's partly why we have such a social stigma. The stigma really began back in, at least in the 50s, if not before, maybe even in the 30s, where there was a connection between using illegal drugs and committing crimes to get money to buy drugs. And so the response, at least here in the US and many other countries around the world, to addiction was a criminal justice response. It was treated as deviant behavior, as criminal behavior to be addicted to heroin or other drugs. And here we are many decades later, and that stigma has not gone away, even though that connection is probably not nearly as strong as it was at one time.
Yeah, I wanted to say also that I find it interesting that the stigma for the medication is still there, because it's so similar to all the other sort of mental health issues that, you know, when people say that they don't want to be on like antidepressants forever, or even people with bipolar, you know, the people don't want to take the medication forever, even when it's really,
Yeah.
really helpful, and it's a continued issue and problem, that it's so stigmatized.
Well, it's because it conflicts with their identity of themselves. It adversely affects their sense of self. They see themselves as damaged and sick and needy and dependent if they have to use a medication. And so I think it's that connotation that creates the problem. Like, why can't I do this on my own? Why do I need a crutch, so to speak? Um, uh, if I need a medication to prevent me from relapsing, does that suggest that maybe I just don't have strong enough determination and willpower? Am I not motivated enough? Is there something I'm missing here? So I think when it's certainly not true for everybody. I have plenty of patients who are on maintenance medications who do fine with it. And if you ask them, would you rather be off the medication? They would say, no, this is working fine. I'd rather leave it alone. So I don't want to suggest that everybody who's on a maintenance medication is unhappy about it. Some people are just absolutely thrilled that such medications exist for them because it makes their life so much better. But you know, at the beginning of treatment, I do spend a lot of time with some patients who really do need medication, helping them get comfortable with the idea and accepting the need for the medication. At least give it a trial. Maybe you don't need it over the long term. At least allow yourself to experience the difference. And um, a lot of people will do it if you present it to them, frame it in that particular way.
Right. Are there other ways that you'd like to see society handle addiction differently?
Well, it's been an effort for a long time among people in the field to help society see it as an illness rather than badness, um, rather than see it as deviance and antisocial behavior. You know, see it as a byproduct of altered brain chemistry. Yes, people are, quote, voluntarily taking these substances, and it's altering their brain functioning, changing their personality. But I think the more we can make individualized treatment available to people, make treatment more attractive, and lower the barriers to getting into treatment. We need to open the doors to treatment rather than make it difficult for people to access treatment. I don't mean that necessarily in a physical sense. I mean that in terms of treatment should not be seen as a last resort and as a throwing up one's hands and as a compromise rather than accessing good health care. Um, if treatment was less restrictive, less onerous, a lot of people avoid treatment because they say, listen, I know what's going to happen. If I go to this program or clinic, they're going to require me to stop right away. They're going to put me on urine testing. They're going to throw me out of the program if I come up positive. They're going to require me to attend these groups and these sessions every week. I don't have the time for this. I don't want to be under such a restrictive program of treatment. I really would rather do it a different way. Now, programs are great and they do provide structure for a lot of people who need it. But I dare say that the majority of people out there who have drinking problems don't want to sign up for a program that's going to require them to stop drinking the day they enter the program or as soon as possible thereafter. They don't want to be pressured to go to AA meetings, for example, even though AA could be offer them wonderful benefits. This concept of starting where the patient is, not where you want them to be, is extremely important. And it's something that can help to lower the barriers to getting into treatment.
Right. Yeah, 100%. So you told us a bit about some of your books earlier. And are there any other books from other authors to do with this subject that you've just been talking about that you would recommend?
Well, among the books that I've recommended to my patients is one called The Heart of Addiction. It's written by Lance Dodes, D-O-D-E-S, M.D., who is a Harvard psychiatrist. And it's a book about the self-medication model of addiction that I alluded to earlier, which is the idea that people who develop problems with substances are medicating something. They're using the substances as tools to manage their internal states, their emotional states, to relieve stress, to deal with unacceptable feelings, whether it's anxiety, fear, sadness, whatever. And I think his book makes a very good case for that. So that's one of the books that I recommend to people.
What was the name of that one again?
The Heart of Addiction. And then another book is by my colleague William Miller on how to control your drinking. And it's a self-help book for people who want to give moderation a try. It's a realistic approach. It can help people evaluate whether moderation is actually a viable option for them or not. So those are two books that I often recommend to people.
Yeah, I'll definitely have a look at them. Thank you very, very much. This was a really, really enlightening interview, Dr. Washton.
I feel like every time we speak to you, I learn more and more. And it's always, even for me on a personal level, it's always, it's very meaningful. And I think it's good that people know that there's a place to go if people are watching this and they need help. The resources are out there.
Thank you.